Okay, we're going to begin again, so this session is entitled Religion and Genomics, Sharing History, Sharing Healing, and we have two very distinguished speakers who Joe Fanning has already introduced to us, so I will just say here they are. Here's Ruth Schwartz Cowan, who will give the first talk, and she'll be followed by David Smith, who will give the second. They each have about 30 minutes. We'll have a short period of questions after each of them, and hopefully a little more time for a robust conversation involving both of them. So, Dr. Cowan.
So there's been a bit of variation in the time that I have been told I'm allotted this morning. And so I've decided, whether it's 20 minutes or a half hour, to scratch the formal version of the paper that I wrote this morning and to follow Larry Churchill's model. Joe, I actually don't want this up until the question period. We can leave it there, just if you don't mind. Okay. To follow Larry Churchill's wonderful model, and to frame my talk as a parable, because that's actually what it is. Historians, after all, tell stories, and I often intend, and this was one case, to tell the story of a mandated genetic screening in Greek Cyprus as a parable. Last night I told it as a different kind of story than what I want to address this morning. So I'm going to tell you what the frame is, then tell you the story in somewhat more detail than I did last night in order to bring out the details, and historians believe very strongly that God is in the details, to bring out the details that make sense for this parable. So the frame this morning is the eugenics movement and the question of whether or not modern genetic screening is eugenics. So in order to put some more detail in that frame, I need to start by telling you a few things about the eugenics movement. I can't tell you much in the time I've got, but I'll tell you what I want to tell you as a way of positioning the story of mandated genetic screening in Cyprus. The eugenics movement arose out of the work of a scientist by the name of Francis Galton, who lived during Queen Victoria's reign. In fact, he was born the year she was born, and he died the year she died. And Galton believed very strongly that eugenics was both a science and a religion, actually. Most of the time when I talk about Galton, I say it was eugenics and a political program. But to be honest, his exact words were a science and a religion. The science was going to explore the character of human heredity, and Galton was sure that he knew what it was going to find, namely that heredity was more important than environment in the development of individuals and in the development of the entire human race. You will notice I haven't used the word genetics, and that's because the word genetics hadn't been coined yet. And so I'm very carefully using the word heredity in describing the origins of the eugenics movement. He actually coined the term eugenics in the 1880s, which was 30 years before the word genetics was coined. So he believed that eugenics was a science that was going to study human heredity, and it was going to prove that heredity was more important than environment. The religious part, or the religious and political part of eugenics was going to put that understanding into practice so as to improve either, in some of his writings, certain races, or in other of his writings, the whole human race. And it was going to do it in two ways, which are called now positive and negative eugenics. Positive eugenics was going to be a way to, various ways he proposed, to get better people to breed more. Galton was a Darwinian. And like other Darwinians, he understood that in the race for survival, the more kids you have, the more offspring you have, the more likely your traits are to survive. And so positive eugenics meant that governments should encourage the best to procreate. Negative eugenics, of course, was the opposite. Governments and religions should see to it that the worst cannot procreate. That people with negative traits we did not want to have in our society or our race or in the human race, should not be allowed to procreate. Galton thought that this was a better religion than the religion that he had been brought up in. And I'll leave that as just a digression. That's not really part of the story I want to tell this morning. So, following this programmatic, or in response to this programmatic suggestions, two societies actually did, no society to the best of my knowledge ever succeeded in mandating or in any way even making acceptable proposals for positive eugenics, but two societies did create programs that were negative eugenics. The first was our own, that is the United States. The second is Nazi Germany. There was also eugenic legislation in Scandinavia, which I can talk about later, but for the moment I just want to focus on what happened in the U.S. and in Germany, because they're different. In the U.S., many states, beginning with Indiana in 1907, many states passed laws which mandated involuntary sterilization, either through tubal ligation. I forget what the technical name, the other technique is. Mandated involuntary sterilization of people in state care whom were thought by the physician in the institution that they, and these institutions were generally either homes for the feeble-minded, that was the term that was used then, or they were prisons and jails. If the physician in charge believed that the trait they carried was detrimental to society, the physician could request sterilization without the consent or even the knowledge of the individual. And many states passed such laws after that. The law in the state of Virginia was challenged all the way to the Supreme Court in the famous Buck versus Bell case of 1927, and it was left to stand. And the end result was, I'm now looking at my notes to get the figures, which showed that between 60,000 and 150,000 Americans were sterilized without their consent under these eugenic laws between 1907 and roughly the middle of the 1950s. The situation in Nazi Germany was different in two important respects. The eugenic laws that were passed in 1933 by very early in the Nazi hegemony in Germany specified that anyone could be remanded for involuntary sterilization. It didn't have to be people in state care. broadened the list of conditions that would warrant sterilization, so they included such things in addition to feeble-mindedness and insanity. The list of conditions included alcoholism, homosexuality, and epilepsy. So anyone could be remanded, not just people on public support. And this is a real kicker for our purposes, any professional, ministers, physicians, dentists, who failed to report such a person to the eugenic courts could be fined. A whole court system was established to adjudicate these cases. An enormous number of geneticists were employed in that court system during the Nazi years. Other geneticists were employed in another legal system that had to do with taking pedigrees to find out who had how much Jewish heritage. But professionals were required to report individuals with those traits to the eugenic courts on pain of a substantial fine. In some cases, the courts sterilized folks. In other cases, particularly with children, they remanded the children, again without the consent of their parents, to sex-segregated institutions for the feeble-minded and for other conditions that would have manifested themselves in childhood. And as many of you probably know, toward the end of the 30s, not by law but by executive edict, some of those institutions gassed their inmates. The technical term is euthanized, but I don't like to use it in this situation. So the bottom of the slippery slope of eugenics is right there. It is in the involuntary sterilization of people with so-called negative traits, and it is in the requirement of professionals that they report such individuals. This was not a requirement in the U.S., but it was a requirement in Nazi Germany. Requirement of professionals that they report such individuals to eugenic courts. Now, the story I'm going to tell you, the story about mandated genetic screening in Greek Cyprus, is a true story. And for me, it illustrates this central point, which is the framework of today's talk, namely that modern genetic screening, even when it is mandated, is not only not eugenics, it is actually the opposite of eugenics. Despite a whole lot of rhetoric, which those of us who read this material have encountered over and over and over again, with every month it seems to me there's more of it, that says that modern genetic screening is eugenic. I'm telling you this story in an effort to demonstrate to you not only that it is not eugenic, but also that it is anti-eugenic. So, beta thalassemia, the disease that they screen for on Cyprus, is a blood disease. It's one of the hemoglobinopathies. Like sickle cell anemia, it's a single gene recessive disease. Heterozygotes or carriers have one copy of the mutated gene. They're reasonably healthy. Homozygotes have two copies, and they are the children who are afflicted. Like sickle cell anemia, beta thalassemia is found all over the world in places in which malaria was once endemic. The disease was first identified in the United States in the 1920s. In fact, in the United States, it's still called by the name of the pediatrician who identified it, and that is Cooley's anemia. It was first identified in the U.S. in the children of Greek and Italian immigrants to the U.S. It is, as I said last night, a dreadful disease for two reasons. The disease itself is dreadful, and the treatment that has been developed for it is equally dreadful. Babies who are born with beta thalassemia do not make adult hemoglobin. They appear to be completely normal at birth, but around 6 months they become listless, and their rate of growth and their development slows down. Then doctors say, this child is anemic, and try the various techniques, or used to say, this child is anemic. They try the various things that are supposed to alleviate anemia, and nothing works because this child is anemic in a completely different way that can't be resolved. The child, if left untreated, will die a slow and basically listless death sometime between the age of 4 and 6, but in the interval, the child will develop certain physical anomalies, anatomical anomalies that make it, the disease you can't not know that the child has thalassemia rather than ordinary anemia, and I'll show you a picture of such a child during the question period if you want to see it. Now, thalassemia therapies were developed in the United States and Great Britain. The first of them was developed in the mid-1930s. Pediatricians who were caring for these children decided to try, knowing that their blood was really defective, tried to see what would happen if you transfused such a child. And they actually discovered that a transfusion brings a child out of the listless state into normal levels of childhood energy, but not for very long. It takes about a month, and then the child reverts to being listless. So they developed a regimen in urban areas that had very advanced medical infrastructure, developed a regimen of monthly transfusion for the children. They couldn't do this with very many children, obviously, until after World War II, because as some of you may know, it was during World War II that the techniques of blood banking were developed. When they were transfusing thalassemia children before World War II, the donor was sitting there, and the donation was happening in real time. But after World War II, when blood banks began to appear in hospitals, more and more children, thalassemia children, were put on the regimen of monthly transfusions. And the pediatricians were heartened to discover that the children, A, were lively, they didn't develop the physical stigmata of the disease, but they were saddened after a period of time to realize that the children were dying in their teens. And they were dying from basically an overload of iron. They were getting concentrated transfusions. Their bodies were not able to clear the iron that was left over from the destruction of red blood cells, which goes on all the time in our bodies. And so their major organs were failing because of elemental iron overload. In 1960, an iron chelating drug was put on the market. Chelation means to hook on, and this drug, which is called still by its trade name, Desferal, was a chemical which combined with elemental iron to make it water-soluble and therefore excretable. And within a few years after Desferal came on the market, a team of British physicians who were pediatricians caring for thalassemic children in London began to realize that Desferal, if given by infusion, successfully cleared the excess iron from the tissues of children with beta thalassemia, thus making it possible for these children to have an average or nearly average potential life expectancy. And by 1980, many of these children who had access to Desferal and transfusion treatment since infancy had in fact reached adulthood. Unfortunately, there is a world of pain and suffering in the 4 words that I just used, if given by infusion. Infusion takes many hours, and for most thalassemics it has to be done daily. A small pocket-sized pump has been developed for this purpose. Thalassaemic babies are often put to sleep with it. Adolescents and adults usually do their infusions during quiet times of the day. The insertion is done subcutaneously in a vein using a sharp hollow needle, which means, of course, that it is painful. And in order to be completely effective, babies need to begin their infusions and their transfusions about the age of 6 months. So this means that parents must, in order to keep their child healthy, insert that needle every night. So the world of pain and suffering is not just the suffering of the patient, but it's also the suffering of the caregiver, of the parent, who has to do this and has to somehow maintain a nurturing relationship with the child at the same time. As you will come to understand, I hope, all that pain and suffering experienced not only by the patients but also by their parents and the medical professionals who care for these families. And now I'm not talking about caring for the patients, because pediatricians who deal with thalassaemic children are dealing with the whole family, leaving aside the genetic characteristics of the disease. The medical professionals who care for these children and parents is an essential part. That is, the clinical experience is an essential part of the mandated genetic screening program for this dreadful disease. So I need to tell you quickly something about Cyprus. It's the second largest island in the Mediterranean. It has, as I said last night, Cypriots have one of the highest carrier rates for beta thalassemia in the world. 1 in 7 Cypriots, whether they are Greek or Turkish, is a carrier, which means 1 in 49 marriages is between, on the average, or can be expected to be, between carriers. At the time that my story begins, between 75 and 80 babies, thalassaemic babies, were being born on Cyprus every year. In square miles, geographically, Cyprus is quite small, but right now, and since the middle of the 70s, it has been split into 2 independent national units, which don't recognize each other as independent national units. The southern part, I actually will use this. This is a Turkish Cypriot map of the island, and I don't know whether you can see it, but the capital city, is there a pointer here anywhere? Well, I don't want to take the time. The capital city, which is in the middle of the island, is called, to us, Nicosia, but to the Turks it's called Lefkosia. So the English and Greek name is in parentheses beneath the bolden word Lefkosia. These 2 parts of the island, which are demarcated by that line, are separate governmental entities. The bottom is the Republic, the south is the Republic of Cyprus. It's the entity that's represented in the UN and that has general diplomatic recognition. The top third of the island is the Turkish Republic of North Cyprus. It is only recognized by Turkey, and it is not recognized diplomatically by Cyprus and by all of the other nations of the world. It's important for the story that I'm going to tell you to understand that both parts of the island are parliamentary democracies. Neither one of them is a dictatorship in any way, shape, or form. The Cypriot Orthodox Church is the established church of the Republic of Cyprus, and that happens to be one of the many reasons why the northern third of the island is separately governed from the southern part of the island. Both parts of Cyprus mandate premarital carrier screening for beta thalassemia, but the mandating authority differs, and I'll only say a little bit about this because I want to focus on the southern 2/3 of the island. But in Turkish Cyprus, the mandating authority is the government, Indeed, the law mandating screening was one of the first laws passed by the Turkish Cypriot parliament when it came into existence in 1979. In Greek Cyprus, however, the mandating authority is the Cypriot Orthodox Church and not the government itself. And thereby hangs the very complicated historical story that I'm going to try to tell you very quickly now. Medically educated Cypriots had learned that the population of the island had a very high carrier rate for beta thalassemia in the 1940s. When Cyprus became independent from Britain in 1960, it inherited a fairly good medical infrastructure, especially in Nicosia. And it also became a member of the British Commonwealth, which meant three important things. The first was that medical professionals could go to Britain for advanced training. The second, that large numbers of young people could go to Britain for training. And the third was that patients who could afford it could go to Britain for treatment. And so it was that by the mid-1960s, Cypriot medical professionals, both Turkish and Greek, became aware of the advances that were being made in thalassemia treatment, both in transfusion and in chelation. So they set aside a separate ward in Nicosia General Hospital for transfusing thalassemic children. And by 1970, the parents, both Turkish and Greek, who had met each other there, had started to form what would today be called a patient advocacy group. It was then called the Pan-Cypriot, notice the usage there, the Pan-Cypriot Anti-Anemia Society. The society began to pressure the government, to lobby the government into creating a blood bank, which up until then Cyprus hadn't had. And it also tried, successfully, to pressure the government to cover the cost of desferal therapy. Desferal was then, and still is, extremely expensive. The rich parents who were importing the drug on their own had come to realize that their less affluent peers were having trouble getting access to it. In the first decade of independence, that is between 1960 and 1970, when the Cypriots themselves were keeping track of their census, roughly 80 thalassemic babies were being born every year on the island. And as I explained last night, they soon realized that they were in a medical moral crisis, that the cost of desferal was going, if more babies kept being born and thalassemics began to live normal life spans, the cost of desferal was going to wipe out the budget of the Ministry of Health in a few years, and it was going to wipe out the whole budget of the island a few years later. In addition, supplying the blood needs of thalassemics was going to require that every Cypriot adult donate blood every 6 weeks in perpetuity. So they began to think that something had to be done, and what they thought should be done was carrier screening for beta thalassemia, voluntary carrier screening for beta thalassemia, so as to counsel parents about the reproductive risks that they faced. This was in the mid-1970s, just at the time when Cyprus was being split up by civil war. And so for the moment, the rest of my story is all about Greek Cypriots, not Turkish Cypriots. They started the voluntary screening program with the siblings of their patients and soon discovered that that wasn't going to work because parents didn't want to find out, and they didn't want their kids to find out whether they were also carriers, because that would make them not very attractive on the marriage market. So they branched out, and the branching out is important to this story. They branched out to try premarital screening, and to try premarital screening with groups of young people they could lay their hands on. One group of young people they could lay their hands on was Army recruits. And so they screened a lot of Army recruits, and they quickly discovered that though they told the young men what their carrier status was, the young men promptly forgot and never mentioned it. As they entered into marriages. By this time, prenatal diagnosis has become possible for beta thalassemia through fetoscopy, the technique I told you about last night, enormously invasive and very dangerous procedure, both to the mother and to the fetus. But it was possible to find out whether the fetus being carried by a carrier mother in a co-carrier marriage was or was not thalassemic, and the physicians discovered that women who already had one child with thalassemia were willing to go to London when pregnant again and to undergo this procedure, and if they discovered that the fetus was thalassemic, to terminate the pregnancy in London. This led them, the physicians in charge of the program and the parents in charge of the program, to try a different strategy, and that was to talk to obstetricians on the island and see if they could get the obstetricians to convince pregnant women to go for screening. Okay. That process helped to reduce the birth rate of thalassemic children somewhat, but not entirely. And as I explained to you last night, that led the physicians and the parents to go to the Orthodox Church, to the Council of the Orthodox Church, and ask the church to help them create a mandated program. I want to tell you, in the time that I've got remaining, the arguments that the parents and which, as you know from what I said last night, the church agreed to do despite its opposition to abortion. Because the only therapy consequent on the negative diagnosis is abortion. They made 3 arguments, and they're each significant to my story about eugenics. The first argument was that the church should do this in order to reduce the level of pain and suffering in its flock. The second argument was that the church should do this in order to encourage the flock to be fruitful and multiply. And I need to explicate that a little bit, because the doctors had discovered when they went to prenatal screening that women who discovered that they were carriers married to carriers were terminating all of their pregnancies. So the argument to the Archbishop and his council was framed in terms of that reality. With prenatal diagnosis, with premarital screening, followed by prenatal diagnosis, the number of abortions being performed on the island would decrease. Because only, on average, 25% of those fetuses would turn out to be thalassemic fetuses. So women who were carriers would stop terminating all of their pregnancies. They would only be terminating 25% of them, on average. There were actually 2 arguments in there. One was that mandated screening would lower the number of abortions happening on the island, and the other is that mandated screening would encourage carriers to be fruitful and multiply. And that's precisely why this program, even though it is genetic screening and even though it is mandated, is not eugenic. Because what it does is encourage the carrier to keep having children. The eugenicists, if Nazi Germany had occupied Cyprus in the 1930s, the eugenicists would have sterilized all of these people unquestionable. What mandated genetic screening is doing is telling them to have more children. And that's why it is anti-eugenic. Thank you. I actually did it?
That was great. Wait, stay here.
I have to.
So, we want to take about 10 minutes now for any questions that are going to be directed specifically to Dr. Cowan's talk. So, and let me ask you, please, if you have a question, to introduce yourself at the beginning so we'll know who you are.
Good morning. My name is Dr. Joy Riley, and I have a question for you, Dr. Cowan. Over here.
I'm sorry, there you are. Okay.
Did that, in fact, reduce the abortion rate in Cyprus?
Yes.
Can you give us numbers or anything like that?
No, I can't. I only know that the answer to this question is complicated. For much of the period of time that we're talking about, abortions were not performed on Cyprus, and Cypriot women who wanted them were going to Israel, which is very close by. The thalassaemic patients who wanted them were going for prenatal diagnosis to London, and therefore they were getting the abortions performed in London. The only data the folks in the Thalassemia Center have is for the patients that they were following, or the mothers of the patients they were following, because they were taking care of all the travel. The travel was being covered by the Ministry of Health. And that's the reason why they know. For other women, and there were other reasons why women wanted abortions. They don't know anything about it. Now abortion is legal on the island, and so they know how many are being performed on the island now, and for whom, but they can't compare it with past data because they don't know.
Joel Frater from Chicago. I understand you're an historian, and that may make it tough for you to address this question, but now that there's at least one and maybe two effective oral chelating agents,
it's going to change everything.
How do you think the story will change?
It's a terrific question. Oral chelation avoids this pain and suffering because, as its name suggests, it can be taken by mouth. I don't know enough about it to know. At the time that I was on Cyprus, it was in trials, and the physicians who were expert about thalassemia were terribly worried that it would not be as effective. And even slightly less effective can change everything for a thalassemic. Do you know whether the current ones on the market are as effective as infusion chelation?
I'm not sure that we know as much as we would like to, especially for very young children.
Yeah,
but
and we don't.
They seem to be effective.
Right. And we also don't know long term. And of course, the important question is long term. But were it to turn out that oral chelation works, I don't think that the Cypriots, at least, I can't speak for, and there are many other populations that have beta thalassemia, high rates of beta thalassemia. My suspicion is that Cypriots would stop terminating were that level of pain and suffering to diminish, and were the burden on the mothers, and after all, it's the mothers who carry most of the burden of caring for the children. Were the burden on the mothers to decrease, and the pain and suffering of the mothers were to decrease, my guess is that they would not terminate.
Dr. Bonnie Chakravorty, and
sorry.
I have kind of a historical question. You were talking about positive eugenics movements, and
Let me just interrupt you for a second to say that I have another thing to add to that answer, but I'll do it after your question. Go ahead. Or do you want me to do it right now?
yeah, why don't you do that?
Okay. One of the reasons, and it just occurred to me, that one of the reasons I can be fairly sure of that is that while I was in Cyprus, the government licensed a pre-implantation genetics clinic. Now, the folks who wanted to put it on Cyprus weren't really interested in Cypriot. They were putting it there to serve the Saudi and Kuwaiti population, which is nearby. But the government did was to tell them they couldn't have the license unless they treated thalassemic couples for free. And a whole lot of thalassemic couples took them up on the offer, preferring pre-implantation diagnosis to termination.
Thank you. I wondered if in Nazi Germany the Lebensborn movement, if you would consider that to be an example of a positive eugenics movement, as well as the programs that the Nazis had to increase the birth rate among Aryan mothers.
You're absolutely right. That was positive eugenics, and I was wrong in saying that. I didn't know of any government. I don't tend to put Nazi Germany in the same category as governments in my brain, and that correction you're absolutely right. The Lebensborn program you've probably heard of, but you may not have heard of the name, was to choose wonderfully and perfectly Aryan-looking and healthy young women to bear the babies without marriage of SS officers. Lebensborn means well-born or live-born?
Leben is life.
Yes.
Lebensborn, yeah.
But this...
The other phrase was lebenswertes Leben, which is life unworthy of life, and that was another one that was bandied about, and it was written by a psychiatrist and a general medical doctor.
It is breathtaking when you understand how many medical professionals were involved in these enterprises. The program to encourage large families amongst the Aryan population, which was a program under which the Nazis forbade abortion. And did they also forbid the sale of birth control technologies? I can't remember. But in any event, their intention was to provide they forbade abortion for the Aryan population. Abortion was legal for the Jewish population. They forbade abortion to the Aryan population, and they, for a time, offered bounties, that is, sums of money, for each child over 2. That is, not the age of 2, but each child after the second.
Hi, Ruth. Charles Bosk, University of Pennsylvania. The last question made me wonder why you would not describe the Cypriot experience as positive eugenics, as opposed to not eugenics.
Oh. Well, that's another problem of my brain, which is I don't want to use the word eugenics for any of this because of its negative connotations. And because the word has been used rhetorically by passionate opponents of genetic screening over and over and over again. I mean, it's the main claim they make about what's wrong with genetic screening, which is that it's eugenic. So people don't really think of eugenic in positive terms, and that's why I don't want to use it.
I want to address a question to that specifically. Since I have both mics, I'll assert that authority.
Is that a source of authority?
I now just have one. I'm Jeffrey Bishop, and I'm here at Vanderbilt. And what I think, I do a lot of reading in the disability rights movement. And one of the things that they persistently say is that, well, positive eugenics is not has not really been instituted by a government, but it's kind of already in place by another powerful institution known as genetics, right? Okay. And it is a way of thinking and not just these things that we use to bring about good in the world. And so they would want to say that, you know, trying to make the case that this is not positive eugenics, selecting, I mean, it's been made most explicitly by the deaf community as well as others, right? To say that, well, you are not enforcing, but just by asking the question, it opens up an option that otherwise would not be there. Now, it's problematic. I think the disability rights community's point is problematic. But I don't think you've gotten out of the problem of positive eugenics, and I'll tell you another reason why. John Harris, a philosopher of law and medical ethics in England, makes the point that, it is eugenics. It is positive eugenics because we're the good guys and we're doing it for good.
That's not a good reason.
Well, I understand that, but you could almost say, and I'm not saying that's what you're saying, but by trying to make the point you're making, you're almost kind of agreeing with Harris in one way. If you think of the power of medicine and not the power of government as instituting a positive eugenic policy.
I'm going to have to think. I'm afraid I can't answer that question on my feet. I'm going to have to think of all the implications. But one did occur to me, and of course this being my 67th year, it just fled my brain. And it comes back to me, but since there are other questions. But there is another good reason, I think. It had to do, when you said that Harris says this is positive eugenics, but it's still eugenics because we're really good folks and we're doing it for the, quote, right reason, is that the eugenicists were regarded in their day as really good folks, A, and B, one of the arguments made by medical geneticists and human geneticists about why what they're doing is not eugenics is that we're right and they were wrong. It's actually the case. That is, they were wrong. They could have sterilized from natal doomsday. It wouldn't have made any difference in the populational distribution or prevalence of the conditions they were sterilizing for. And clearly genetic screening does make a difference in the populational prevalence and incidence. So we're right, they're wrong is also not a good reason, in my view.
Okay, let's just take one more question, and I'm going to ask Dr. Phillips if he would close the session, and then we'll have a little more time later on, okay?
So as a ex-Navy medical officer who's involved with newborn screening in Tennessee, the question I have is, we screen for 60 different disorders in newborns. And the rationale we use is that we are, with the screening, sorting out those who are at high risk for a disorder for which there is a positive intervention and that it will reduce morbidity and mortality. That sometimes is attacked as eugenics.
In that it also gives reproductive instructions or reproductive information to the parents and the child if somebody ever tells the child? Is that what you're referring to?
Some couch it as a search and destroy mission.
Really?
Yes.
When they do that, search and destroy is the colloquial term for what can otherwise be called selective abortion. Are they referring to out of the 60 conditions, my understanding is that a number of them can be treated, but another portion of them, no treatment is known. It's just information. So when they talk about search and destroy, are they talking about the conditions that can be treated or the conditions that can't?
I think they're sensitive to the fact that some people, and you may not be familiar with this concept, that for some people a normal child is a disappointment. And that any imperfection is one that the parents may choose to have interventions, perhaps prenatal diagnosis, perhaps abortions, and that people view this all under one umbrella.
Well,
some people view this under one umbrella.
Right. My first reaction, since your original question, if I understood it correctly, was what do you think about the critique that newborn screening is eugenics? My first reaction is that I can screen, you can screen, we can all screen, but we can't force the caregivers to provide the therapy for the child. And so it's not eugenics. It's not mandatory. It's not involuntary. I mean, it's not voluntary. Even though the screening itself may be involuntary, as it is in most states of the Union, the therapy is entirely voluntary, and they are free to not provide it. And I believe that there are many instances in which the parents can't be located, and then the therapy is not provided, or they don't know whether it gets provided or not. But I believe there have been instances in which people have withdrawn from the therapeutic.
Tennessee makes its business to not let any of those parents not be notified. They're all notified. That's why we do the screening.
But it does happen, I'm told, in other states, that without staff, you can't sometimes locate all the parents once they've left the hospital.
Thank you. I'm sorry about the hands we didn't recognize, but there's time. And it's now my pleasure to introduce David Smith, who has already actually been introduced, so I won't do that again, but just say, here is Professor Smith.
I don't need this baby. This is going to be a change of pace in more than one way. To start with, I'm going to read a little bit more than my predecessors have done. When I started out, longer ago than I'll publicly acknowledge, I wrote things out because I thought if I didn't, I would get up and be so terrified that I wouldn't have anything to say. Now it's important for me to write things out, because if I don't, I will warm to my subject and go on forever, which after a fine program is one thing I feel sure you don't want me to do. I'm going to be talking about religious doctrines, specifically about Christian doctrines. And I begin with an assumption, and this is in the context, remember, of our overall conference, in which we're focusing on the sort of interface between clinical genetics on the one hand and religion on the other. Now, as Larry said in his opening remarks, religion doesn't present itself as such. Religion presents itself in certain specific forms. And Judaism, Buddhism, Islam, and all those traditions that I just identified, there's countless subgroups. I'm going to talk about Christianity, and I'm going to talk about it in a kind of idiosyncratic way. I don't claim to speak for any particular denomination, but I do always have in mind, and I'll make it pretty explicit at some points, Christianity as it enters into a conversation with clinical genetics. Now, in the back of my mind is the following idea, that at least with Christianity, and I think with many religions, we can distinguish between the kind of core practices or beliefs, core practices or experiences of a tradition on the one hand, and the doctrines or conceptual forms that come out of those experiences or practices on the other. And I take the view that these doctrines or beliefs should always be thought of as to some extent fallible. That's to say, they are revisable. This is not the time or place to argue or elaborately defend this view, but I think within Christianity at least it's really indisputable that there's been extraordinary doctrinal change over time. It's just a matter of historical fact that not all Christians always have or always will or always in different parts of the world believed the same things. You see the risk, though, when I go off the text, because see what I just did it. There are 4 points about the relationship between Christianity, health, and genetics that I want to make. First, I think it's imperative that Christians affirm the value of health for themselves and for others, by which I mean to include both physical and psychological health. You may think, duh, but I'm going to do it anyway. Second, Christians should not think of health, including genetic health, as the highest value in life. The greatest compliment to be paid to a Christian at the end of her or his life is, boy, was she healthy. Third, a crisp distinction between illness and morality, between genetic problems and sin, must be established because of issues of guilt. Fourth, serious Christian faith requires human beings to work to reduce genetic pathologies and to help everyone live with the genetic limitations we all have. Whoopsie, excuse me. Whoopsie was not part of the text. Despite you can see the risk you run when I get the podium. Despite some excesses in the ascetical strand of Christianity, and baby have there been some, the Christian tradition has pretty darned consistently affirmed the value and goodness of health. With health, by health meaning a body that functions well and a capability accurately to understand and effectively to accomplish one's goals. That commitment to a healthy body would have been very difficult for the Jew Jesus to reject. And in fact, he did not. Now, it's true that Jesus can scarcely be seen as a precursor of the late 20th century attendant at a health club or the YMCA. In fact, we know virtually nothing, and it's interesting, we know virtually nothing of Jesus' health before the crucifixion. What we do know is that stories of his healing miracles, are pervasive throughout the New Testament. He clearly treated ill health as a bad thing, not as a discipline to be endured, but as something to be got rid of. And by his presence, or his words, or the faith he engenders, according to the New Testament texts, he is presented as a healer. Nor is, as some more contemporary philosophers have put it, the concept of health problematized. The blind do see. The insane are made whole. Problems of menstruation are corrected. Even the dead are raised. Read, as former colleague Luke Johnson used to say, on the flat, these healings are clear affirmations of the value of a healthy life. Theologically, we can find more support for this idea in the doctrine of the importance of health, in the doctrine of creation, that mythological claim that despite all the injustice and sickness and wretchedness in the world and all that is therein is God's product, and therefore, at least to that extent, good. I believe that this notion of health as something objective is a legacy that it's very important for Christians to preserve. Being healthy is not just a matter of someone's own opinion. People can be ill and not know it. and whole cultures may gloss over certain requirements of health. People may think they're sick and not be. That's the meaning of being a hypochondriac. In effect, I'm saying that I don't think it's right to say that all genotypes are created equal. Some of us are fated to worse health than others. That's point one. 2, health is not the most important thing in the Christian life. The most important thing within this tradition is certainly one's relationship to God. In some Christian writing, that's described as love for God. In other places, it's described as faith in God. The first formulation is more characteristically Catholic, the second more Protestant. I personally like the formulation that says that the ideal relationship between the self and God is one of trust and loyalty. But the core idea isn't uniquely mine, or it goes way back, and at least in sort of the within the history of doctrine, it goes back to Augustine's analysis of human nature in the 4th century. Now, the implication of this for our work together is really pretty simple. Insofar as we have to choose between health on the one hand and a proper relationship with God, that choice is pretty much a no-brainer for the serious Christian, and the relationship with God wins. There are times when we have to make a choice between loyalty to God and health. Martyrdom is a clear case of people who have chosen faith over life. But so, there's lots of other things, less than dramatic martyrdom. Hard work for any worthy cause. In fact, it's not a particularly rare occurrence that people do this. People jeopardize their health all the time in working for their families, their church, or their country. And laying down your life for another person and working very hard for a cause is not good for your health in the ordinary sense of the word as we use it. Put differently, trust and loyalty to God allow us to see preoccupation with health as a kind of idolatry. It's putting health in the place of God. Margaret Mormon is a wonderful pediatrician and Episcopal laywoman on the faculty at the University of Virginia. Suggests, I'm going to quote Margaret Mormon just a little bit, that this idolatry is shown in, and I quote, fickle, shifting obsessions with diets and exercise machines, and with jogging down, I love it. Excuse me, you can see why I love it, but I do. With diets, Margaret is incidentally not a teeny person. The path of vitamin C or brewer's yeast or no yeast at all or oat bran, Margaret Mormon goes on to claim that the preoccupation with health represents a failure of trust and absence of a fundamental attitude of confidence that we have been created as far less fragile creatures than we fear we are. Children do not, she goes on, routinely need artificial vitamins. Menopause is not a disorder that routinely requires therapy. A cough is, and I quote Mormon again, God's brilliant mechanism for clearing the airways, unquote, and need not always be suppressed. Most dangerously, as Mormon goes on to point out, preoccupation with health leads us to forget that death is something to be expected as part of a healthy life. If one lives to be healthy, then death can only be construed as a failure, the enemy to be fought at all costs. But if one lives with trust and loyalty to God, then death can be accepted because it's not the ultimate loss. So, for the Christian, I'm winding up point 2. I think I'm okay on my time. So, for the Christian, health is a good, but it is a secondary good. It is, as the philosophers might say, an intrinsic good, but not the highest good. And Christian ethics seems to suggest that my neighbor's health is more important and valuable than my own. That ethics provides a rationale for physicians and nurses working long hours, clergy and laypersons tiring themselves out visiting and caring for the sick. The obvious implication for our purposes would be that the genetic health of others is something I should worry about much more than I do about my own. This leads me to the third point I want to make. This Christian, what was Mary and Larry's wonderful phrase? The Christian and the genetic interpretive schemes have two things in common. Have at least one thing. Maybe they got 16 million, but I just want to talk about one thing at the moment they have in common, which is they are both essentially relational. They both are essentially social. Our genes come from some persons and may be handed on to others. Christians, on the other hand, therefore, Christians must claim that genetic basis is a part, but only a part of our identities. Unfortunately, however, Christian theology has sometimes made a stronger claim concerning the relationship between genetic health and social health. It has suggested a causal connection between the two. That is to say, that genetic problems are the cause of, or in aid of learning, are the cause of, or in aid of moral evil or growth, that they are related in some way to the idea of sin. That we either sin because we either have genetic problems because somebody did something wrong, or we have genetic problems so we can suffer through them and learn to be better people. Now, this view, the connection between moral failure or sin and genetics, is in fact pretty clearly repudiated in the New Testament. For once, this is unlike my style, but in fact, in the Gospel of John, chapter 9, verse 2, the Christ is asked whether a man's illness is a result of his or his own parents' sins. The assumption between the connection between illness and sin is assumed. The question is, did he do something to deserve it, or did his folks do something that he got the problem? Jesus responds that neither of these things is the reason, but the man is ill, so, quote, the works of God may be manifest in him. Presumably meaning that this will be the occasion for a demonstration of God's healing power in the Christ. Note, Jesus doesn't say that illness may not have any divine purpose, but he does say it's not connected to somebody's moral failing. Nevertheless, it's just undeniable that linkage has a part in Christian theology and practice today. Christian ideas about sin and bodily problems have a real legacy of moralism. In the Augustinian tradition, to which I am extraordinarily indebted, ill health and death are often explained in terms of God's punishment for sin. In another tradition, named by scholars today after French, very early, like 3rd century, French theologian Irenaeus, the idea is that these health problems are, as I suggested a minute ago, useful to us before they provide a gymnasium, if you will, a kind of gymnasium for our moral workouts. They provide a context in which we can learn to be better people. You laugh. It's no joke if you're coping with it. In both cases, there's a connection between health, morality, and salvation. But the Augustinian tradition puts God in the position of punishing well beyond any imaginable justification. And the Irenaean one makes God a kind of non-directive instructor in very inefficient terms. Now, so there's that doctrinal legacy. There's also contemporary practice, which I bet all of you have seen. We Christians are not at all exempt from a kind of moralistic attitude towards health. I learned that a friend has lung cancer. Somebody I knew had lung cancer. My first question is going to be, was he a smoker? I learned that someone has some other kind of problems. Did he drink too much? I'm going to ask. That kind of attitude where we're really asking, was it his fault? I'm making this a guy. Was it his fault? And we want to say it was. Everybody knows smoking leads to lung cancer. He smoked. He brought it on himself. Part of the impulse for this behavior, I think, and I do not claim to be above it, is self-protection. His cancer was the result of smoking. I don't smoke, so therefore I have a much less chance of getting cancer. This, of course, is magical thinking. I want to concede that people do, in fact, have great responsibilities for their own health. But ill health is, in fact, distributed in ways that are entirely inexplicable. The moralistic tendency to blame the sufferer accomplishes very little. Now, when we take this kind of mindset and we move it into the world of genetics, there's a terrible risk that people will think the birth defects in general, including the genetic problems of their children, are in some ways their fault. They may not, this may not be syllogistic, but the feeling is there. I think this is an issue that theologically needs to be taken on in a much more robust way than it has been so far. Let me explain quickly. This is going to be a sort of slight detour, but we're going to get the ship home just about on schedule. Historically, forgive, this is going to be slightly arcane, but I hope I can make it intelligible. Historically, there have been at least two main theories, theological theories, about the origin of the human self. The first was called traducianism. The Latin root is tradere. It's the same root we get our word tradition, which means passed along. The self was passed along, which held that the human soul was entirely the product of the biological contributions of woman and man. Of course, thought that the male contribution was more important. But the point was that the whole self was really formed from the selves of the parents. Now, from the point of view of the church's doctrine, that view had one huge advantage, and that is it fit well with the notion that sin was original. That's to say, sin was with us from the very moment of our origins. Sin is treated on this theory as a kind of biological contagion, a sort of species-wide genetic defect. So, the big gain in the theory, theologically, was an explanation of why every human being, needed to be baptized and needed I'm quoting a great church father, the medicine of immortality that the church had to offer. But there was an even greater theological defect, and that was that individual souls had no particular relationship to God. You've got God setting up the thing and this whole mechanic of contagion going on without God having any particular relationship with the rest of humankind. So a more modern, forgive the term, theory came about, and it was called creationism. Not what you're thinking of now in late 20th and early 21st century debates, but creationism understood in a different way. It's found in the work of the theologian Thomas Aquinas. It goes back before him, and in fact, it persisted as formal Catholic dogma well into the 20th century. Creation holds that God infuses the soul into the developing body at some stage early in gestation. 40 days for males, 90 days for females. I can't remember exactly, and the details are beside the point. The point is you've got biological development going on, and at some stage, at some point in that developmental process, the soul is, quote, infused, unquote. Thus, each individual soul is personally related to God. We all are directly God's creatures. But sin has to be ascribed to the influence of the bodily host. So you get a theory in which sin is more crisply associated with the body than in the first theory, and incidentally, and this is really a sidebar, it can clearly justify a more liberal position on abortion. Because until this time of infusion, you're not really dealing with the human soul. Now, you guys, end of that long discursus, long sidebar. In my view, neither of these theories breaks the connection between sin and genetic disorders with sufficient force. Neither captures the insight ascribed to Jesus in the Gospel of John. If we look to either for clinical support or help, we are going to come up way empty and with very dirty hands. Now, I want to suggest that there's another way to go at this. And I'll try to do this really quickly. All this is under point 3, which is the longest point. Fear not, 5 minutes. And that theory is the theory developed. It's arguably the most interesting and important theory of sin developed in the 20th century. And that was by the so-called neo-Orthodox theologian Reinhold Niebuhr. And I want to give you Reinhold Niebuhr's theory of sin in one of my 5 minutes. Niebuhr argued that the best way for us to understand ourselves is as finite spirits. We are spirits in the sense that we're able to understand ourselves and each other, we're able to love, we're able to have empathy. That's the sort of cognitive and emotional, spiritual side of ourselves. But we're finite. And one of the striking characteristics about being a finite spirit is that we know we're going to die. The result is that human life is always lived in a kind of background condition of anxiety. Insecurity is just an inescapable feature of what the jargon phrase used by these guys is the human condition. Moreover, we know about each other. We're comparative. He's got more time left than I do. She makes more money than I do. We tend to think comparatively, and we tend to think with anxiety. Now, we try to get rid of this anxiety. One way in which we do it is we try to we drown it out. Niebuhr called this sensuality. And there's some obvious forms, but the form that's quickest for our purposes today is substance abuse. Be it alcohol or drugs or whatever, you forget about. That's a wonderful relaxing thing about this stuff. But the more characteristic way we try to resolve this problem, Niebuhr thought, he's a big, strong, very vigorous guy. The more characteristic way we respond to this stuff is by denying our finitude. We tend to absolutize our own projects, our own hopes, our own vision, and we tend to want to beat the next guy. When I do this comparison, I don't want to make just as a decent salary. I want to make a better salary than the director of that other center down the road. We tend to think in these kinds of comparative terms, putting down the other and putting up ourselves. Now, there is the possibility, Niebuhr argued, of love, in which we really put each other's needs above ourselves. But he thought that was rare and literally miraculous, that most human life is lived under this rubric that I've just tried to sketch. Pride in particular is original sin for him. That's to say, it's rooted in our nature as finite spirits. Now, if we were to take, I'm going to go over but not a lot, if we were to take a Niebuhrian approach to sin and genetics, we would find ourselves focusing on issues of power imbalance, on disrespect for difference, and the importance of the provision of moral and spiritual support for patients, families, and their caregivers. Thus, for example, we might respond to the so-called disability critique of genetic ethics by affirming that we tend insufficiently to support persons living with genetic tough draws, that our social institutions make life rooted in genetic differences more difficult than they need to be, and that the only way to ameliorate these problems is through the use of social and political power. On the other hand, we would not ascribe innocence to people suffering from genetically disadvantaged bodies. We would not suggest that no genetic differences are objectively disadvantageous, or be reluctant to call genetic blindness, congenital blindness, or deafness handicapping conditions. Moralism is replaced by ambiguity. There's no innocence and purity out there. But ambiguity does not mean insensitivity to injustice, to the need for reform, or the importance of the miracle of love. This leads fourth and finally, and you'll be glad to know it's about a 3-paragraph issue, This leads, fourthly and finally, to recognition of the fact that the moral issues produced by genetics are ultimately not moral. They're not just moral problems. The issues we face in genetics and healthcare are typically not between good and evil, but between limited goods all bought at a price. They are religious issues. Religious issues in the sense that Larry beautifully outlined in the opening talk. The point of religions of salvation, of which Christianity is certainly one, is that they offer a way to live with moral ambiguity and problems. Some religions do this through a notion of rebirth. Some traditions do it by saying, if you live right with it, you'll end up very happily in a next life through immortality. I think it's better to see that the core claim of Orthodox Christianity is that the Christ identified with humankind in his suffering. That identification with us is the core of the salvation that he offers. Salvation doesn't mean, I think, this is in some ways very idiosyncratic. Salvation doesn't mean we cease suffering. What it means is that the sting of suffering is gone because we don't suffer alone. Think of the gruesome pictures of the Christ in historic Christian art. What we're seeing is he had it as bad as we do. Now, if that's right, and the real source of salvation is the identification of God with us, then the question of why someone's suffering isn't very interesting. The core thing we should be thinking about is, what should we do for each other? If my identity is one who can live with ambiguity, I should try to help other people live with ambiguity. Like genetics, salvation and responsibility are social. They require commitment to care and justice and respect. Throughout, I've tried to explain that Christians should be dedicated to genetic health as we ordinarily use that term, but that such health is not the highest good for which a Christian should aim. Genetic health should be seen by Christians in a theological context, one that avoids moralistic theodicies, notices what we can do to help or hurt each other, and stresses a realistic hope for a life of trust and loyalty. When we have to choose, we should choose personal integrity over improvements in our own health and care for those suffering from genetic disorders more than enhancement of ourselves or our descendants. Thanks. I think that the drill is right, that I get some, and then Ruth and I.
The drill is that you get 10 minutes.
Okay.
As the single target, and then we enlarge
and we
the
have to
bullseye.
we get Ruth.
Yes.
Ruth gets to come up.
Okay, my name is Jan van Eijs. I'm, among other things, a pediatrician at Vanderbilt. First of all, thank you for that talk. But my question is, language is so important, then why do we call certain examples of genetic diversity diseases? Who is the sinner and what is the sin? Isn't it true that that really hides the unwillingness of society to adapt to the problems that person might pose?
I think it's a really good point. What I want to say, I'm appreciative of an argument that one glory of the world is genetic diversity. That said, I don't think I want, and I wonder if you want, to draw the conclusion that there is no such thing as a genetic anomaly or problem that you'd be willing to describe as a bad draw in the genetic lottery. I'm just looking for a way. I would not mind discarding the word disease, but I am very concerned about suggesting, well, as I said, I intentionally used some very provocative examples. I referred to congenital blindness and congenital deafness as, it seems to me, to be, objectively speaking, handicapping conditions. I'm quite aware of some of the literature people relating in particular to persons who are hard of hearing and that culture. But I do think I guess I don't think that Christianity necessarily needs to do this, although, well, let me stop. I am babbling.
Well, even using the word handicapping is equivalent to disease. It's handicapping because society is structured in such a way that we don't have room for that person. The classical example is the village Geel in Belgium, where being mentally ill is not a problem. They take them in, schizophrenics are perfectly at ease there, and society is at ease there, and the Belgian government has figured out it's cheaper than using medical treatment. So we can create a society in which genetic variants are perfectly acceptable. They may take more care, and therefore we may have to be willing to give that extra care.
Pardon me for interrupting.
No, I'll stop there.
I'm very sympathetic with the normative claim. I entirely support it. And I don't mind at all, in fact, I know I should, find better language to use than disease or handicapping condition. That said, I must say, and I don't mean to be this to be an ad hominem challenge, but I do think it's a little disingenuous if we deny that there are some draws in the genetic lottery that are better than others, and that there are some very bad draws that, if we're not going to call them handicapping conditions, maybe something that would make life impossible in any conceivable society. I don't know. Now, I think it's fair game to ask me, why do you care so much about that? Why make that point at all? And I guess the best answer I can come up with at the moment, who knows, maybe I'll decide I just am dumb to make this claim. But I think one reason I want to do it is because I think there is a complete relativism on this point may cut the nerve of our incentive to really do some things that we can do to help people. If we say, it's sort of the reverse of a genetic essentialism. It's saying that the whole problem is social. Well, I guess I don't think that's right. There's someone in the back.
Oh, okay. As someone who is afflicted with a genetic condition, I have a genetic form of emphysema. I would say that, yeah, I have a disability, and it isn't so much an issue of you can call me handicapped, you can call me disabled, but call me. That's where the emphasis, I think, should be.
There's, who are you? Yes.
Timothy Jackson, teach Christian ethics at Emory. Just in the name of giving credit where it's due, Niebuhr got it all from Kierkegaard.
Oh, thank you for this.
So it was
you
really
can't rise and speak without getting someone to footnote you.
Right, exactly. Yeah, and alas, Niebuhr didn't give the footnotes himself as much as one would have liked. About the suffering of Christ, you say it's perhaps healing, redemptive, and I would agree because we can identify with Christ's suffering. But what about the notion that it's even eliciting a kind of schadenfreude over, that he has it worse than we do, and there's a kind of relief in knowing this fact? How do we put the brakes on valorizing suffering, and how do we put the brakes on, especially in the Christian tradition, on seeing it as a sort of at least instrumentally good, if not intrinsically good? Just could you say a little bit more about what's the proper place of suffering in the Christian life?
Not only my references, but the big ideas. Let me give a short answer rather than try to give a short answer rather than a long one. I think it's important to see that the Christ in the New Testament never says, go ahead and suffer. When he sees suffering, he heals it. I think that's a model worth bearing in mind. On another level, I guess I've found myself, there is one strand sometimes in Christian ethics about medicine and health that seems to suggest if we work to correct those problems, then people won't suffer anymore, and so a good life will no longer be possible. To which I say, baloney, or some similar epithet. People are going to suffer. The fact that I'm not making them suffer or not letting them suffer or I'm helping them out of suffering doesn't mean they're not going to suffer. Come off it. The world does that to people. Life does it to people. And the thought that the right response to another human being in need is to say, well, it'll be good for you to live with that problem. I'm not so sure. Now, it is true that there is such a thing as paternalistically sheltering people from the realities of life, or people being unwilling to confront some experiences and difficulties that are just part of a serious life, the need for self-discipline or a variety of other things like that. But that's a little different, I think, from saying, well, if we don't do that plastic surgery, she's going to live the rest of her life disfigured, and it will be good if she learns her life will be enriched as she copes with that. I'm very uncomfortable with that kind of a response. It's one thing for me to decide that. It's another thing for a health professional to say, I'm not going to get those services. I appreciate that my example moved out of genetics. Was there someone else?
Right here.
Good.
My comment was in regard to your passage from Scripture that you read. I thought that was an appropriate one. I think you also have to look at the fact that Jesus throughout his ministry was constantly at odds with the Pharisees and the Sadducees, the church leaders of the day, for their preference for demagogic oblivion to one's own inadequacies. Because what Jesus also said is, when I am gone, you will do greater healings, you will do greater things than what I have done. And yet you look around in the world of the church today, and we don't see that. We don't see that happening. Therefore, it's convenient and easy for anyone in the church to say, oh, well, they have that because of their sin. Well, why is it that they, as a church leader, are not doing those things greater than Christ's ministry that he talked about? Is there not a sin there if there is a sin that causes the person to be in the position that they're in?
I certainly do not take the view that the church is sinless. I mean, I think, to the contrary, actually, more like a company of sinners. But I guess the only other thing I'd say is that, in fact, Christianity as we know it in the United States today has actually a pretty good legacy of being concerned with health. A lot of our hospitals, I'm not familiar enough with the Nashville scene, but a lot of our hospitals were founded by Catholic orders or by Jewish communities or by various Protestant groups. And that really, but what's happened is that the costs have so exceeded what they can do, and then the government's taken over. In many ways, health has replaced salvation as the cultural preoccupation. And we put oodles of tax dollars, hugely increasing amounts of tax dollars into it. I don't think that means there's no role for religious communities. I mean, one of the reasons I think this project is quite wonderful is because I think organized religious communities have tended much too much to fumble the ball, to have the conceptual stuff all wrong, to not listen to professionals, to not provide support for people. My own biggest hang-up has been with care for the dying. But there's just no doubt at all that the genetics issues are, in fact, harder to talk about in a congregation than care for the dying is.
Okay. I see Dr. Cowan. I didn't see you in the back early. Would you come up, please? And we have just a little time. I've been told by Dr. Fanning, who's, the all-knowing eye here. So let me ask if there are questions.
When we give them PhDs, maybe.
That's right. That's right.
You've got to respect them.
Let me ask if there are questions that anyone would like to address to either or to both of our speakers for this morning session. Maybe there were some left over from earlier. Gail.
Can you hear me?
No.
This also has nothing to do with genetics. It's actually, as someone who knows next to nothing about Christianity, I have a request for a clarification, actually, based on something that you just asked. So I heard you say that what is healing is that the sufferer identifies with the suffering in Christ. I heard you say, and this may seem like a minor point, I think it's an important one, though. I heard you say that what's healing is that Christ identifies with the sufferer.
Yes, that's right. But it goes both ways. But you're exactly right. I mean, people who object to my view of this, of whom there are many, are going to say, essentially, well, David, what it amounts to is misery loves company. That what I say is all you get out of it is the fact that you don't suffer alone. But it's a little bigger. It's not just that I don't suffer. It's that there's something fundamental about the world that's identified me. But there's an important sense in which I'm sort of cosmically not alone. But I suspect Tim may well find that inadequate, and as I say, he wouldn't be the only one. It's the only way I can make sense of it, however, which is why I stick with it.
I'm questioning about it's not just the misery loves company point. It's the disclosing of vulnerability on the part of the powerful one.
Yeah, that's right.
So, I mean...
You guys, let you guys fight it out.
Well, just real quickly, because I know we're near the end of time, I think it is partly that misery loves company. I think, again, there can at least sometimes even be the thought that he's suffering even more than I, and so there's sort of better him than me. But even more deeply, I think the most positive and powerful dynamic is that this is innocent suffering. And this is, I think, a point that David has made, that some would equate Deuteronomic theology with if you suffer in this life, you must be sinful. If you prosper, you must be virtuous. Job, I think, is the Old Testament answer to that. No, there's such a thing as innocent suffering, undeserved affliction. I think, in a sense, Christ is making the same point on the cross. Here's the Son of God, innocent, and yet still suffers, is still forsaken by the Father, and still experiences anxiety. Doesn't sin, but when Christ says, Eli, Eli, lama sabachthani, that's anxiety to the nth degree.
Which means,
so,
my God, why hast thou forsaken me?
Right. And one can then identify oneself with that, well, maybe my own suffering is both bearable and sometimes at least innocent.
If there's not another one, I would like to perform a little dialogue because I would like to ask Ruth a question. Will that be?
Absolutely. As long as I have a little bit of time to respond to another dialogue.
Why don't you better go first.
Okay. I'm sorry, I've forgotten your name, Dr. Van Eyck. Raised a point that's been raised many times about the concept of genetic disease and even about the concept of genetic disability. And in my research about, as it happens, newborn screening, I noticed something which I've always wanted to have an opportunity to ask an informed audience about, and so this is the moment. One of the important actors in the story of PKU screening was the National Association for Retarded Citizens, which was its old name. In fact, they were the folks who funded the research that led to newborn screening for PKU. They are the ones who lobbied the governments of the states to make it mandatory. They were very active in that effort. Why were they very active in that effort? They were the parents, most of them the parents of retarded children, who had organized in the interests of their children's lives. And they'd organized to do a whole lot of social and environmental reform that would help their children to realize their potential. So why were these folks anxious that there be mandatory genetic screening of newborns so that the PKU infants could be identified, so that they could start dietary therapy, so that they would not become retarded? That was the whole point. It seems to me that, in effect, what those parents were saying was, yes, we must do everything we can environmentally and educationally for the children we have. But we also must do everything we can to make sure that whomever can be cured of this disease does get cured of this disease. And that is the recognition that David was, I think, talking about, that you can at the same time recognize that something is a disease or a disability and work as hard as you possibly can to make sure that the lives of those who have it are as equitably lived as possible.
Let him respond.
Of course, that means that society accepts that disorder, if I may use the term, as something worth responding to. But I would also make a claim that you cannot cure a genetic disease. You can only minimize its impact.
Right. I use that verb cure inappropriately.
Could I have my try now? I really, I just thought your talk was splendid. But of course that's going to prefix. This is the way the way the world works. What I wanted to raise a question of is, let me put it this way. I'll put it as a challenge rather than trying to be artful. Some people refer today, I'm thinking particularly of a man named Michael Sandel, who wrote an article and now has a book, I think it's called Against Perfection or something like that. It's very short, it was a long article and a short book. I'm not sure how different they are. At any rate, he refers to what he calls free market eugenics, in which we no longer have the kind of compulsory behavior that was done in the U.S. and to a much, much worse degree in the Third Reich. But we do have a situation in which something of the same thing is going on, but through individual choice. And as part of that argument, he makes the interesting claim that the genetic reformers like Galton of the of the 19th century, he says they at least had a social purpose in mind. That's to say that their idea was that they wanted to try to improve society. Now, people who want to do a lot of genetic stuff, they're not thinking of improving society. They're thinking of making more money and of individual advancement for themselves or their children. End of comment.
That's packed with many, many issues, which I can't all address briefly.
I only wanted to...
But a big bomb.
Throw a bomb at someone you know can handle it.
Let's hope. Not that I can handle it, but that people will stop throwing bombs at people who can't handle it.
Go on.
Sandel's point, I think, is the same as Troy Duster's point, and the title of his book makes it even clearer, that is, Backdoor to Eugenics. What we're doing is not eugenics in the way in which the Nazis did it and we did it as Americans. We're doing it under the banner of voluntary, and that's why he calls it a backdoor, but that we're going to get to the same place. And my contention is, A, that we are not going to get to the same place, and B, that the fact that the intention is not to get to the same place makes the whole matter completely different. The intention of eugenics was, as you said, to improve the human race, or to improve society by improving the abilities of the human race. The intention of modern genetic screening is to relieve pain and suffering. And the perfection issue, which is in Sandel's title, is a red herring as far as I'm concerned. And it's a red herring precisely because of abortion and precisely because of the alternative method, which is in vitro fertilization. I contend that nobody is out there seeking perfection in their offspring or in all of our offspring. Nobody is doing this for the purposes of enhancement, making people taller, blonder, blue-eyed, and that furthermore, individuals are not going to terminate pregnancies, as I said in regard to the answer to Joel's question about oral chelation. We know for a fact that most people will not terminate a wanted pregnancy for something as minor or morally empty as blue eyes and blonde hair. They just won't do it. Furthermore, I don't believe they're going to go have in vitro fertilization, that is, to not enjoy the pleasures of sex, but rather go and masturbate in a closet and take hyper-ovulatory medication just to get a taller kid. In fact, why would they pay for something which is both free and fun?
All right. Okay, one more. Mary.
I just feel that maybe one piece of this confusion could be cleared up. Eugenics literally means good genes, whether it's administered through public policy or individual decisions. It's used in a variety of ways by different people, and I think part of the confusion over your Cyprus discussion has to do with that final claim saying this is not a eugenics. But it is, if you think of it only in terms of trying to promote good genes through whatever policies, individual or group choice. That's, I guess, all I needed to say.
Nonetheless, that may be what it means. In fact, when Galton coined the term, the word gene, the concept gene didn't even exist. And so what his English translation of the Greek roots was beautiful heredity. But it is nonetheless the case that if we call it eugenics, we are covering it with a negative overlay. A pall, to use a term we were talking about.
It's history has given us that.
History matters.
All right. Let's thank both of our speakers for an excellent session.